Hello, dear friends, and welcome to our weekly online meeting with IVMED Fertility Centre specialist. Today, we have really interesting topic, and our topic is ovarian reserve, AMH, ovarian rejuvenation technologies with PRP. So today, we will talk about ovarian reserve, testing and how to improve it, PRP technologies, when you use your plasma to help your ovaries to grow egg cells. Also, we will talk about low AMH and quality of oocytes and methods of improving embryo quality, using support chip and calcium ionophore. So, our speakers today, our fertility specialist and our embryologist, Galina Strelko, MD, PhD, fertility specialist, obstetrician gynecologist, member of ESHRE, ASRM and UARM, and also head doctor and co-founder of Medical Center IVMED. And also Olha Maliuta, Master of Science in Molecular Biology, Senior Embryologist at IVMED Embryology Laboratory, ESHRE member, and also a member of our Embryology Laboratory of Medical Center IVMED. Just to remind that we have an active chat when you can ask all your questions during our presentation. And we had some questions that our patients sent us before the webinar, and we also answer all the questions. So, please, Dr. Galina, start your presentation.
Thank you very much. Good afternoon, dear friends. I'm glad to participate in our webinar. Now I need a couple of minutes to open my presentation. Okay, and we will start. So today we will talk about ovarian reserve testing, about markers of ovarian reserve, and about possibility to improve this ovarian reserve if it is not so good. So why the testing of ovarian reserve is so important? Why we discuss this topic? Because this ovarian reserve means the number of follicles and potential eggs or sites which we can obtain during ovarian stimulation. And if we understand well the ovarian reserve of women, we can understand better what kind of stimulation we should use. We can also understand the probability of pregnancy in IRT cycle. Also, we can understand if, for example, menopause will occur early or late. And for some specific technique like pronuclear transfer, we should also understand if we have enough eggs or not enough. Also, in some cases, it permits us to identify how we can say hopeless or patients who are not who have no good chance to become pregnant after our treatment. So in some cases, we propose to these patients egg donation program, for example. So what is it, ovarian reserve? This is the number of follicles and eggs in ovary in some period of time. To control, to understand, to check this ovarian reserve, normally we use the molecules which in normal life regulate the growth and maturation of follicles. This molecule's name is anti-Müllerian hormone, inhibin B, ESTRODIOL, and FSH. All these molecules participate in recruitment of follicles, in growth of follicles, in ovulation partially. So after we will discuss each of these molecules. So this table, you can see the different markers of ovarian reserve. We have a lot. It is biochemical, biological, biophysical, genetic, etc. Biological, what does it mean? The most important biological marker is age, because age of women is detrimental to, how to say, oocyte quantity and quality, and we will see later why. Biochemical, we can divide into part like static and dynamic. Dynamic is different tests. We can give some medication, then measure something and see if ovary working well or not. But now we don't use a lot of this kind of tests. We're using mostly static, FSH, LH, etc., different hormonal molecules. Biophysical markers, it is mostly ultrasound. We can see ovary, we can measure ovary, we can calculate how many antral follicles we have at this time. We can measure blood circulation, and it permits us to make some prognosis of ovarian function. Important things is genetic markers. Why? Because in some cases, maybe some modification of receptors of ovary, and in this case, ovary doesn't respond as we expect. For example, if we have mutation of FSH receptor or LH receptor, we can see a lot of follicles, but during stimulation, they will not grow in well. So it is important to know that it exists, some kind of genetic marker of ovarian reserve. So, age, our first marker of ovarian reserve. This picture shows very nice people who decide to become married, but we can understand that in this age, for sure, they will have not very good possibility to become pregnant by natural way. We know that woman has, how to say, final number of follicles, not women born with some amount of follicles and with eggs, and during the life, the amount of follicles and eggs only decrease, and one day they finished. We can see that optimal fertility is between 20 and 30, 32, 35 years old. After 32, 33, we can constate the decline of fertility. End of fertility normally it is after 42, 43 years old. Okay, it is always very individual, but in most of cases it is after 42, 43 years old. But most of cases, the average age of menopause is around 50 plus minus 4 years. So if woman has menstruation, it is not signify in all cases that she has good ovary and good possibility to become pregnant. For this purpose, we study in each case the ovarian reserve. You can see in this picture different kind of oocytes, and most of them, Olga can confirm, not so good. Yeah, this is the kind of oocytes that we receive in women of late reproductive age. So if we receive this kind of eggs, of course, it will not be good chance to become pregnant. So this factor of quality of eggs, which correlate very well with biological, with chronological age of women, we should always take in consideration when we discuss the fertility treatment. Why we have the decline of fertility with age, even if we have good ovarian reserve? In this picture, we can see the probability to have genetically normal embryos according woman age and according the number of eggs which were received during the egg collection. And we can see that if we have young women less than 35 years old, mostly 100% 90% of cases, we have as minimum one genetically normal embryo. But if we have advanced maternal age, more than 42 years old, we can see that in 37% of cases, we have no even one genetically normal embryo. So it is very important to remember. So chronological age, of course, has a limited ability to predict the response of stimulation, but it can predict the probability to have a healthy baby and delivery. It was described the natural pregnancy and childbirth at age of 57 years old, but okay, it is in Guinness Record Book and it is very rare, and in normal situation, in most of cases, the limit of age when we have possibility to receive acceptable quality own eggs is around 43, 44 years old. We should always take an age into consideration, into account, and when we discuss ovarian reserve testing and probability of pregnancy. Next marker of ovarian reserve is estradiol. Why estradiol is important? We can measure it at the beginning of cycle, because if we have decreased ovarian reserve, normally follicles can start to grow in previous cycle, before menstruation, and in this case we'll have higher estradiol level than in young women. And it was shown in different scientific works that if we have estradiol level more than 80 picogram per milliliter at the beginning of the cycle, it can predict low ovarian response during the stimulation. Another marker is FSH, follicular stimulation hormone. This is the most common used test for assessment of ovarian reserve. Normally, it should be done at the beginning of menstrual cycle, second, third day of cycle. It is very easy and cheap to perform this test, and sometimes it is used in combination with other markers or dynamic tests. FSH unfortunately cannot help us to predict ovarian hyperstimulation syndrome, but it may be very helpful when we discuss ovarian reserve testing. When organization named IVF Worldwide have done the survey of different IVF centers from different countries, you can see here that 196 centers and 45 countries participate in this survey. They asked doctors which kind of tests they prefer for ovarian reserve testing, and this is diagram. You can see most of gynecologists or proctologists use FSH alone or FSH with another markers to identify ovarian reserve. So it is very useful and very common to use this marker. And we can see that the main problem of FSH is the upper limit, because during the last 15 years, this upper limit of normal range changed 3-4 times. And in some laboratory, they say it is 20, in some 10. And from this upper limit depends how many women will be considered as women with decreased ovarian reserve. In most of cases, if at the beginning of menstrual cycle we have FSH level more than 15, maybe 20, it means that really we have decreased ovarian reserve in this case. And also it may be very difficult to make stimulation of this ovary, because stimulation we use normally FSH preparation. If we have own FSH very high, it means that this ovary will not be sensitive to external FSH administration. Another marker which we can use for ovarian reserve testing is inhibin B. Now it is not very popular, but sometimes it may be used. This molecule participate in regulation of ovarian function, and level of inhibin B depends on number of antral follicles also. So lower inhibin B we have, less antral follicle we have. We can see that mostly these molecules are produced by follicles that have a diameter from 8 till 12 millimeters, so it may be useful tool to understand the ovarian reserve better. Another marker which we are using very often is antral follicles count. It means that we are doing ultrasound and we can calculate, count, sorry, how many little follicles we have inside of ovary. Okay, we cannot see all follicles. We can see only follicles which can grow during the menstrual cycle. We cannot see all amount of follicles. But if we can see, for example, 3 follicles, we will give stimulation, we will be able to stimulate only 3 follicles. If we can see 10, we can stimulate 3, we can stimulate 5, and sometimes stimulate all 10. But if we can see only 1, we cannot produce 10. And it is very important to do this antral follicle count at the beginning of each stimulation, and like that make some prognostic about this cycle, about success of this stimulation. In this diagram, you can see that at birth, in general, in ovary, we have around 1.5 million of potential oocytes, and at the age of 4 years old, we have only 3% of this amount. So antral follicle count, very useful to predict ovarian reserve, poor ovarian reserve, and as well ovarian hyperstimulation. If we can see more than 14 follicles in both ovary, it means that we have good chance to have ovarian hyperstimulation syndrome during controlled ovarian stimulation, and we should take it in consideration, use maybe last injection agonist of gonadotropin releasing hormone and not HCG, which produce this hyperstimulation. If we have less than 5-6 follicles, we can talking about poor responder. So, antral follicle count, anti-Mullerian hormone, and age, the 3 main factors, the 3 main markers of ovarian reserve, and they are showing more or less the same. And if we are using all 3 markers, our prediction will be more exact, of course. So, anti-Mullerian hormone, this is the main and most important hormone to predict ovarian reserve. Why? Because this hormone is produced by small antral follicles, diameter no more than 10 millimeters. So exactly only antral follicles. If follicle became 10 millimeters, this follicle loses this possibility to produce anti-Mullerian hormone. And that's why this hormone, more and better than others, predicts the possibility of future stimulation and ovarian reserve as well. So in this slide, we can see that a lot of studies have done about the anti-Mullerian hormone, and was shown that if we have IMH more than 3.5 nanogram per milliliter, it signifies that we can have good chance to have ovarian hyperstimulation syndrome. So this patient may be considered as a very good responder, and during stimulation we should take it in consideration. Also, we should know that laboratory which give us the result sometimes may give some, how to say, not mistake, but there are some kind of variability of this anti-Mullerian hormone. If we have, for example, 1.5, in some situation, laboratory can give us 1, and in some situation can give us 2, and even more. Difference may be even more. Because in some conditions, this anti-Mullerian hormone may be higher or lower than it is in real life. For example, if women take contraceptive pills, it may influence anti-Mullerian hormone. If laboratory use not certified reagents, it may be also not exact. Some method and some machines to control anti-Mullerian hormone are more exact, some of them are less exact. So we should know that if we have only one test and only once and not repeated, and we have some amount necessary to control and maybe repeat in another laboratory and take in consideration another factors and another markers of ovarian reserve testing. And like that, we can receive the more exact response and more exact amount of this hormone. Also, you can see in this table that anti-Mullerian hormone decreases with age. For example, medium at 27 years old, it is 3.5, 3.4. And medium in 46 years old, it is 0.5. So all women has this tendency, but if here at the beginning, at 27 or at 30 years old, women have, for example, not 3, but 10, okay, here at 40 years old, she will have higher number. And just opposite, if here she has 1.5, here maybe menopause. Anti-Mullerian hormone, as we can see, decreased progressively with age and became mostly zero around age of menopause, around 52 years old. What about normal range of anti-Mullerian hormone? This is a very good question, because I remember when at the beginning laboratory started to do this test, there was different normal range. They give normal range, but now they stop give this normal range because normal range depends on age, depends on population. In some population we have higher IMH level, in some more low. Depends on situation, after some surgical intervention, it may decrease. So it depends on purpose and conditions. If, for example, we would like to stimulate women to do IVF treatment, women have around 42, 43 years old, and anti-Mullerian hormone is 0.2. Okay, it is normal for her age. If we will not do IVF treatment, it is okay. But if we would like to stimulate her, in this case, it is not okay. We consider this amount of IMH as prediction of full response. So, in this case, we should take in consideration what is the condition of testing. If we are talking about stimulation, more than 1 till 2.5, it is more or less normal. More than 2.5, it is very good responder. More than 3.5, it is risk of ovarian hyperstimulation syndrome, and more than 5, it is polycystic ovarian disease. If we have very low level, like less than 1 or even less than 0.2, the prognostic to receive good amount of eggs is very bad. Yeah, so we should do thinking about this. In this graph, we can see the number of eggs and level of anti-Mullerian hormone. For example, if we have less than 0.6, in most of cases we will have less than 6-7 eggs. If we have more than 1.5, we will have good number, so around 14 eggs. And this permits us to individualize the protocol of stimulation. Yeah. If we have women which we can call high responder, potential high responder, we should be careful with risk of ovarian hyperstimulation syndrome, and it should be specific protocol, antagonist generation antagonist protocol, minimal FSH dosing, and trigger only with agonists, which prevent this ovarian hyperstimulation syndrome. If we have potential poor responder, we should give higher dose of FSH, we should maybe do ultrasound more often, and also we can do trigger with HCG. Also, it is important to talk in if we have very poor prognosis of fertility. And it was some paper done by American Society of Reproduction, and they write that very important to inform people if the chance of pregnancy with own egg is less than 1%. In this case, necessary to explain that, okay, chance is not good, less than 1%. So you should be aware about that. If you would like to try, okay, but you should know exactly the probability of pregnancy. And in some situation, if we have advanced maternal age like 44, 45 years old and very low ovarian reserve, very low IMH level like 0.0 something, in this case we will have this kind of prognostic, less than 1%, and necessary to discuss different options like egg donation, for example. So, what we can do if we can see with our markers that ovarian reserve is not good? What we can see, what we can do during the stimulation? There are a lot of methods which we can use and we are using normally. So we try, for example, to add estradiol at the end of previous cycle of stimulation. It can decrease a little bit FSH level and also decrease this asynchronous growing of follicles and permit us to receive all follicles which we can see in ovary. Because if follicle growing not by synchronous way, in some situation we can receive only one egg because other are too little or not growing well or start growing later. So it is important to have synchronous response. Sorry. In some situation we can add recombinant LH, and for women after 35 years old, it is recognized by most of scientific papers that it is very helpful because women after 35 years old, they need more LH for adequate response to stimulation. In some cases, we can add growth hormone, which increase the sensitivity of FSH receptor of ovary, and this ovary became more sensitive to our stimulation. In some cases, we can add androgens because women hormones, estradiol, are produced from androgens, and it may improve also the quantity of antral follicles. In some cases, we can add aspirin, which improves blood circulation. We can use specific protocols of stimulation, like natural cycle, like modified natural cycle, like 2 stimulation and one cycle. In some cases, we can do oocyte cryopreservation. For example, 2, 3, 4 cycle, we preserve oocyte, and like that we have some kind of bank of oocyte, and then we use 5, 6 oocyte fertilize. We can do fertilization and then use this embryo for future treatment. And one of the new methods named PRP therapy. After I will speak a little bit about this. So if we have very low ovarian reserve and age less than 40 to 43 years old, because if age is more than 43 years old, normally we have very bad egg quality, so we should have less than 40 to 43. We can use what we call PRP therapy, Platelet-Rich-Plasma Therapy. This method became more popular, like non-operative treatment option in different medical disorders. It is widely used in orthopedic treatment, in sport medicine, in some cosmetologic treatment, and historically, it was started in 1997, 1998, and at the beginning it was used in orthopedic treatment, and technique shown very good results. And after that, scientists start to search another possibility to use this technique. The main idea of this technique is isolation of specific fraction of blood. We take blood of patients. We made centrifugation of this blood several times, and the blood divided in two fractions, red part and white part. Yeah, and then we take some amount of this portion, and in this portion we have very high concentration of platelet, specific platelet. And as these blood cells has a lot of different growth factors and a lot of some specific molecules which stimulate the growing of cells, some processes of formation of tissue, we can use this portion of this whole blood for some kind of treatments. So in reproductive medicine, we can use this therapy in premature ovarian failure, in some situation when we have torsion of ovary and women in this case have the problem with blood circulation in ovary, so ischemic problem, in some endometrial hypoplasia, and in case of implantation failure. Several scientific works shown good results of this therapy. For example, in this work, we can see that group A, it was previously treated with platelet-rich plasma, and another group of poor responder was not. So we can see here higher fertilization rate of eggs, higher implantation rate, and higher clinical pregnancy rate also. And the difference is around 3 times. It is very important difference. In this scientific work was shown that not all women give this good reaction to platelet-rich plasma treatment. But in most of them, we can consult the increase of IMH level in 4 or 5 weeks after the treatment. And around 1/3 of these women give very good result in improve the number of eggs and number of follicles of ovary. So as conclusion, we can say that ovarian reserve testing is a very important part of our infertility evaluation. The essential markers of ovarian reserve are the woman age, IMH, and antral follicles count. IMH indicates only number of antral follicles, but we cannot predict the quality of eggs with IMH. The best predictor of egg quality is age, and PRP therapy may improve the ovarian reserve and probability of pregnancy. Thank you for your kind attention, and I will be happy to answer all your questions.
Thank you for your presentation. So please, our next speaker, our embryologist Olha Maliuta, please start your presentation.
Hello, everybody. I'm happy to welcome all of you. And I will start my presentation. I will talk about some instruments that we have in our lab to improve embryo quality. If we are talking about embryo quality, what is this? Like we evaluate, of course, embryos on every day of their development, on day first, on second, but most important is the quality of embryo of day 5 of blastocysts. So we use like grading system. When embryo has a number show how big these embryos are. Like expandation rate of this embryo. You see 3 embryos, all of them are like have number 5 on their grading system. And also we have 2 letters. One letter will show the quality of intercell mass of embryos. This like group of cells will give the fetus, like future baby. And also we have the quality of trophectoderm cells. They will develop in the placenta. So here we have like AA embryos, BB embryos, because number of cell and the quality of intercell mass is a little bit lower, and the number of trophectoderm cells also is much lower than the first one. And also we have like TC embryos. So you can see we have 3 different types of embryos, and of course this embryo will have different rate of implantation rate. They will implant with different like in different ways. So what in our practice we also see like the decreasing of eggs and embryo quality connected with the age of patient. Of course, if we're talking about a patient with advanced age, so we have a really big impact of genetic factors and also metabolic factors, such as mitochondria or some cytoplasmic protein that doing good signaling in the embryo cells. So if we are talking about genetic factors, they are connected with some processes during egg maturation. We have 2 types of cell division. We have mitotic cell division, and meiosis, the process of eggs and sperm maturation. So the main problem in human, we have very unstable, very genetically unstable oocytes. Because during meiosis and during chromosome separation, we can have a lot of anomaly, a lot of aneuploidy, some trisomy, some monosomic variants. So it's always connected with the number of chromosomes in chromosome sets. So with age, meiosis start to make some mistakes. So we have in women with advanced age, we have a lot of anomaly oocytes, and of course, these oocytes will give this anomaly to embryos. And we have also metabolic part of these factors. And the most important is how in embryo working such organelles as mitochondria. Mitochondria, it's a very autonomic organelle in cells. It produces a lot of energy. This energy embryo uses for cell division, for growing, or even for embryo hatching from zona pellucida. So embryo need a lot of energy. And also this mitochondria have their own small round mitochondrial DNA. So also important to have this DNA without any mutations and like with good properties. Some literature data show us that when embryos start to grow, when oocytes start to grow and like eggs start to maturate, the number of mitochondria must like increase. And in young people, number of mitochondria can be more than 200, like individual mitochondria, and they can tell the number of mitochondria like showing how many mitochondrial DNA we can see in this egg. And in old patients, we have much less this number of mitochondrial DNA. Actually, it's around 100 and even sometimes less the number. Of course, if we have not enough mitochondria, we will have bad process like of meiosis. Also, we will have bad cell division in embryo, bad cleavage in this embryo, and we will not obtain the good blastocyst on 5 days. In our laboratory, we have some instruments to help such people with less mitochondrial level. We can do donation of cytoplasm or pronuclear transfer. It's very experimental like technique, but it shows really good results. But mostly, like what we can do in our embryo laboratory to make the embryo lives much more easy. How we can handle this embryo in laboratory to do all the best for their development. We very like to use embryoscopy, and you can see the culture incubator like embryoscope in our lab. The best in the system, it's when we put embryo after fertilization to this embryoscope, we will not touch it till the 5th or 6th day. We will not, embryo will not feel the temperature change or the change of culture medium environment. So it's much easier to embryo to develop just in this embryoscope. And I can show you the video how embryo develop in this embryoscope and how we can control its main stages of the development. So as you see, it's show pronuclei. Now the embryo will start to cleave and cell division will start. Now we'll start the compaction stage of embryo and embryo becoming the moral. And now to start blastocyst formation of this embryo. And embryo start hatch because we like to do the artificial hatching of the zona pellucida because in that case, embryo, for embryo is easy to take some proteins or some energy from the culture media. The other instrument to check embryo genetics, it's to do biopsy of embryo and really check how many chromosomes has this embryo. There are some aneuploidy or its embryo euploid, so we can check this with biopsy. I will show you also the video of like we do a biopsy. It's a short video, but we during this biopsy we take from we take from 5 to 6 cells from this embryo, and our genetic lab can check the chromosome set of this embryo. We can check it by FISH, like fluorescence in situ hybridization, and we can check 5 or 9 the most important like syndromic chromosomes, or we can send this piece of trophectoderm to NGS testing and to check all rearrangement in 24 chromosomes. Mostly like for genetic testing, there are 3 strategies. I showed you already trophectoderm biopsy, but we can do also biopsy on 3rd day and to take just 1 cell of the embryo, or even to do checking of oocyte. We can check first or second polar body of the oocyte. Now we want to start like doing this biopsy of polar body in the regular base to check our donor oocytes. It will be very important because we can propose to our patients like oocytes that are really good in with really good genetic and they are tested already. And like this 3 photo of one embryo shows that embryo really can survive after biopsy. It's not a traumatic like some procedure. You can see the embryo before biopsy. You can see embryo just right like 1 second after biopsy. You can see the trophectoderm piece that we sent for genetic testing, and you can see this the same embryo after 2 hours after biopsy. It's completely like open again, and you can just even you cannot see the place where this biopsy was taken. So it's for checking like genetic checking, biopsy, it's a very good technique. Also in our laboratory we can like do artificial oocyte activation with calcium ionophore. Why we doing like this procedure? After sperm fertilize the egg, like on egg membrane start to develop like electricity signal, like the electric wave, and for some oocyte this like electric signal didn't start even. Oocyte like just in some way do not want to make this activation and to start embryo development. So exactly after ESHRE, after fertilization, we can add some calcium ionophore to artificially activate this egg, and even we have some like experiments and just we monitor our results. We even publish results that every step of embryo cultivation, like fertilization rate, are much higher with calcium ionophore, and blastocyst rate are much higher with using this media. So it's really important to do this artificial oocyte, artificial activation, especially for oocyte with both bad quality. And also, if we are talking like how we can make the embryo lives easier and the life of egg easier, it's just to choose the normal spermatozoa for fertilization. We must choose spermatozoa with good morphology, and especially it's important to choose without any DNA fragmentation. Like oocyte will not spend some resources just for making some changing some mistakes in sperm. So we must choose spermatozoa very well. And this little device, it's called sperm chip. we have some entrance, small entrance for native ejaculate. We do not prepare some like ejaculate and sperm some in special way for this device. We just add some spermatozoa, and we have exit for really good spermatozoa, because in this device, sperm cell must go through very complicated like maze. In this device, they have traps for bad quality sperm cell, for sperm cell with DNA fragmentation. So in result, we will have just very good morphologically and genetically without some DNA fragmentation sperm cell. So of course, with this sperm, embryo will develop much better and in easier way. I will gladly answer to the question and thank you for your attention.
Okay, thank you, Olga, for your presentation. It was really interesting, and we already have a lot of questions, but don't have much time. So if we don't answer your questions, you can always send us an email with your questions, and we will always answer them. So we have our first question to Dr. Galina. Hi, I have low AMH, 0.8. I'm 32 years old. Want to try IVF with my own eggs, and I've heard that human growth hormone helps to grow follicles. Is it true? Thank you.
Thank you for your question. Very good question. It is true. When we are using growth hormone during the controlled ovarian stimulation, we receive a better number, higher number of follicles, and follicles growing more quickly. And we don't need, in some cases, to increase dose of FSH, but have good response in the same dose. So it is really true.
Okay, thank you. We have our next question to Olga, our embryologist. If the embryo quality is bad, what are the chances of pregnancy?
Okay, thank you for the question. If we are talking about AA quality, the very best quality of embryos, it's always implantation rate between like 41-55%. If we are talking about BB and maybe BC rate, it's always like 10 or 15% lower. So we are talking about 20-30% of pregnancies, but of course, if we will have bad embryo quality, we will transfer it, because sometimes this embryo gives very good pregnancies and live birth, so we need to try, of course.
Okay, thank you. We have a question to our doctor. Hello, I'm 42 years old. My AMH 1.2. I want to try my own stimulation and also considering egg donation. Should I try PRP or just go straight to egg donation? Thank you.
Look, good question. 42 years old. AMH is good. 1.2, it is not bad for this age. And in this case, we can expect to receive around maybe 10, around 9, 11 eggs, something like that. So as for me, I think we can try as minimum one stimulation to see the quantity and quality of eggs, to receive embryos, make genetic test of these embryos, and maybe we will have good result with own eggs. If not good, or if not good response, or if no healthy embryo, in this case, yes, will be a good idea to thinking about egg donation. What about PRP? PRP improve the quantity of follicles, but not quality. So, okay, we can try, but with IMH 1.2, the quantity is not bad. So in this case, it is there is a question of own eggs or donor eggs.
Okay, thank you. Also, we received an question to our email to Olga, our embryologist. I have 2 embryos, 4 BB and 3 BB. the 5th day, is it better to transfer both of them or only one?
Mhm. Thank you for the question. Of course, if it's BB quality, we can recommend to transfer both of them. Because if we have, for example, like AA quality, we can go with single embryo transfer. Yes, but it's only in case when our doctor says that we can transfer both embryos, because it's, of course, it's higher possibility to have to have twins,
Multiple
pregnancy, and it's always some risk. So just if our doctors will allow us to do it.
Okay, thank you for your answer. So we actually received a lot of questions about PRP technology. It's actually really new, and our patients are interested in that technology. And we have a question. I had chemotherapy last year. Can PRP help my ovaries? And also, I have another question. I've heard about stem cells treatment, and is it similar to PRP technology? Please, Dr. Galina, explain.
I will
Thank you.
try to answer. First question about chemotherapy. So in some cases, after chemotherapy, there is no antral follicles because PRP therapy does not produce the new follicles. This therapy only permits to activate existing follicles and prevent some excessive apoptosis of these follicles. So if after chemotherapy all antral follicles are disappear, because this is sometime arrive after this kind of treatment, in this case PRP therapy will be useless. Necessary to see the exact name of medication, the dosage, how many chemotherapy treatment was done, so necessary to see the previous history, but in some cases it may be useless. But it may be helpful if 1 2 follicles is still in ovary and we can activate a little bit this ovary. About stem cell therapy, it is a little bit different. Okay, principle more or less may be the same, to give some kind of growth factors which can activate inner reserve and inner resource of ovary. But the mechanism of action is a little bit different. And as for me, PRP, this is something absolutely blood. There is no complication, no risk. With stem cell therapy, it is not completely studied and not always easy to answer. Is it really safe? Which kind of complication we can have in 5 years and 10 years? So it is a little bit different.
Okay, thank you for your answer. Also, we have several questions to Olga. If AMH is low, does it mean that my embryos will be bad quality?
No, of course not, because we can have, we will have less eggs, but they can be good. So they're not correlated.
I have a question to embryologist. My husband has 21% of DNA fragmentation, and do we need to use a sperm chip? Actually, it's really important question for our patients.
Actually, 21%, it's in normal diapason. We say that higher than 30% of DNA fragmentation, it's really high risk to have bad embryos or do not have them at all. Yes, but 21% we can go without sperm chip, but of course it's really safe technique. It's really an easy technique, and if patient wants, of course, we will we recommend to do sperm chip anyway, because we will choose just like the good sperm, and we will completely exclude the sperm factor from our embryo cultivation, and it will not have some bad like
Quality, yeah,
yes.
bad quality, yeah. Well, thank you for your answer. And I see the last question also about PRP technologies, quite popular today. Are there any side effects after PRP? Please, Dr. Galina.
Theoretically speaking, it should not be. But of course, if there is some mistakes like maybe not sterile blood preparation or something like that, but otherwise should not be, because it is own blood cells, should not provoke allergic reaction, should not provoke some side effects, only maybe during injection in ovary maybe bleeding, but not a lot of side effects described with this technique.
Okay, thank you for your answers. Thank you to our speakers, and that actually was the last question. And I'd like to invite our patients to our next webinar. It will be next Friday, and our topic will be about embryos, methods of selection, quality, and we will talk about how to choose the best embryo for transfer. So please, you are welcome. If you have any questions, you can send them before the webinar to our email, and we will answer them during the webinar. So have a nice weekend. Thank you to our speakers, and be safe. See you next Friday.
Thank you very much to your kind attention. See you.
See you.
We'll be happy to see you in our clinic.